Hello everybody, I'd like to welcome our audience tonight, wherever you come from. I'd like to thank my three fellow panelists for joining us tonight on this first hangout that I've actually done as a host. Now, all of you in the audience have two knees, so we're all in the same boat at the moment, and all of our knees are incredibly vulnerable because the femur bone, the thigh bone, is so very close to the surface, and especially if one is involved in impact sports, the knee is particularly vulnerable. So I'm going to introduce myself and then my three guests. My name is Sheila Strover. I'm known here for my work with the Knee Guru website. That's KNEEGURU. This is a website for people with knee problems where they have a safe space to discuss their problems, to look for help, to find information. And that's the work that I predominantly do. And my fellow guests, I want to start first of all with Janet Hamilton. I'm just going to show her and not ask her to speak right at this moment because we'll get back to that. Janet is a running coach. She's a qualified physiotherapist and exercise physiologist from Atlanta, Georgia. And she'll be taking the point of view of trying to prevent injuries in sports people that she deals with. Debbie Davis is actually well known on Google Plus as a strategic marketer for social media, but she's here to represent the weekend warrior. She lives in Denver, Colorado, near the mountains. She skis, she climbs, and she's very familiar with the sports injuries relating to the knee. And finally, our guest today is Dr. Jack Farr from Indianapolis, Indiana, and he's going to show us, he's going to tell us about this person who we're going to see the slides of. He's going to explain the procedure that he does frequently for patients who have had a bony injury where the joint surface has been damaged. So we'll get back in a moment and talk to each of our panelists. Okay, Janet, I wonder if you could just say a few words for us and just tell us what your working world is about and the sort of injuries that you commonly see with your runners or that you try to prevent with your runners.
Well, I actually do try to prevent as many of them as I can, but honestly, when you're working with adult athletes who are age 20 up to 70, there's oftentimes a lot of pre-existing conditions, and what I try to focus on is getting as much hip strength as possible because many of the knee injuries that occur in runners are related to muscle imbalances, so I focus on that. But I'm very curious about this particular type of surgery because so many elderly runners have got cartilage defects or articular cartilage defects, and if this is a way for them to be able to continue their sport without having to undergo knee replacement surgery at such a young age, this might be something very, very valuable for them.
Okay, thank you for that. We'll come back to you in a minute, all right? And Debbie, can you tell us a little bit about your fellow sports people, what sort of worries and concerns they have in relation to their knees and their sports?
Well, you know, most of the ski racers that I spend time with are wearing some brace or another, and usually during the summertime when we're keeping in touch over Facebook or something, we're hearing about everybody's knee replacement surgery that they're having done during the off season so that they can get back to the sport. And so I just see a lot of knee replacement surgery, and it's not always elderly people. I mean, well, elderly, you know, relatively speaking, they're in their 50s, which I think is too early, you know, to have knee replacement surgery. But it's, you know, ski racing is dangerous, and all sorts of injuries happen that way. And I'm kind of excited to hear about the possibility of having a procedure that's less invasive and maybe has less recovery time and possibly higher success rate, so that maybe some of my friends won't have to be having knee surgery or knee replacement surgery.
Okay, thank you, Debbie. Now, what I'd like to talk about now is the fact that Dr. Farr, and I'm going to get to him in a moment, is a specialist not only in knees, but a specialist in preservation of knees to try and help people not end up with a knee replacement. So all the interventions that he does are actually at an earlier stage than one sort of traditionally thinks of getting involved with a knee surgeon. So I'm going to put him onto camera now and ask him to explain what he's going to show us, what kind of work he does in relation to sports people with this kind of problem.
Well, thank you. I think what I need to do first is to kind of lower some of these expectations. I and no one in the world right now can prevent a knee replacement when you have end-stage arthritis. So when it gets to the point of bone-on-bone changes, it's pretty much to the point of metal and plastic. Now there are some in the younger individuals, so we can do partial knee, sort of almost partial knee transplantations, but that's pretty far out there. What we're going to talk about today is a little further down the scale. So this is a technique that I've been doing since 1998. Unfortunately, in the United States, this is the same technique that we're still only able to use. Many of my friends in Europe, Australia, and Japan have second and third generations already, but it's all based upon cell therapy. And cell therapy in this technique is using some of the patient's own chondrocytes. The chondrocytes are the little cells that actually keep what we see with our naked eye, the cartilage. The cartilage, I have a little knee model here, I just happen to keep in my pocket all the time. So I think you can see this knee model.
Yeah, that's...
And you can see that here's the femur bone. And then on the end, you can almost call these two little knuckles. These are called the condyles. And in the patient, we're going to see the inside condyle. It's called the medial condyle. So if you put your knees together, that's the medial condyle. You can see this is white, and this represents the articular cartilage. The articular cartilage, as you said earlier, is the material that's actually living, that's covering and protecting the bones. If the analogy is a tire on a wheel, if we had cars with little cells in the rubber, we could have tread that would stay there forever. And in an uninjured knee that has a good genetic background, the cartilage can last a lifetime. And in fact, I was just talking to a reporter today about, is arthritis inevitable as we age? And the answer is no. Unfortunately, we have so many risk factors: genetics, alignment, sporting injuries, other trauma, obesity, lack of exercise, that many people do as they age have more problems with the cartilage. So the intervention that we're doing right now is typically directed at those less than age 50. So there's certainly a huge number of those, and our goal is to take these people with injuries, and instead of them going continually downhill, is to have them sort of level off and maintain their knee function and comfort.
Okay, that's a superb explanation. Thank you. We have the slides that you helped us to prepare, and Debbie's going to show them one by one. What I'd like to ask you, Dr. Farr, is to go slowly through the slides, and at the end of each one, we will see if there's any questions from the audience so that we don't lose anybody along the way. And we've got a comment here from one of the audience, Carolyn Capern, who says she loves the knee model. So that's great. And so does Greg. So that's two people that love the knee model. I think that particular knee model is used in every knee surgeon's office around the world. So yeah.
Certainly is.
Okay, now Debbie's got the first slide up, so I'm going to show that. If you can walk us through them, and if you need to blue box her, Dr. Farr, just to bring the slide up.
All right. Well, this is a healthy teenage girl that had a small region of her knee. Actually, the bone was having a problem. The condition is called osteochondritis dissecans, It's very rare among the normal population, but in my practice it's not uncommon. And what happens is, as the knee tries to heal the bone, many times there's a problem with the cartilage overlying it. It's much similar to if you have an asphalt road and there's something with the underlying material, say there's rocks under there and they get washed out. Well, initially the asphalt is going to look fine, but over time, if you drive the trucks over it, the asphalt is going to break up and you're going to have a pothole. And so in this case, that's what happened. So she has a pothole in her knee. The little cursor is showing the lesion, and around the lesion you can see that pristine, shiny white material. That's the articular cartilage. That is what's protecting the bone. It's about 2.5 millimeters thick, and in this case, the surrounding tissue is completely normal. So she just has an isolated pothole, which is, as you can see, relatively large. So that's the problem. The next slide is going to show the initial management. So in this area, you can see now it's gotten a little larger, and what we've done is remove any questionable material and clean up the margins so they're nice 90-degree or vertical margins. And you can see at the base it's sort of pink to red, but there's no active bleeding. So that's because the bone in the past was injured. Now it's healthy, so that's why it's red, and we do not have the tourniquet up now, and you don't see any bleeding. So it's very important to have what we call good hemostasis or control of bleeding.
Okay, can we stop there just for a moment, please?
Yes.
Leave the picture up. We might want to go back to the first one as well. And if anyone from the audience or our fellow panelists just want to ask any questions, now's a good time to ask them.
I've got a question, Dr. Farr. I mean, you mentioned that this patient was a teenager with osteochondritis dissecans. Is that what you consider to be your ideal candidate for a procedure like this?
Certainly the younger patients do better. And the osteochondritis dissecans, it depends upon what the history is and how the bone is. In other words, the good point is the rest of the knee is completely normal, and usually the environment of the knee is good. So that's the positive. Something that may kind of come up and bite you is that the bone can at times appear healed. It can be almost appear natural, and yet over time you'll discover that no, it's not. So we have to be sometimes more aggressive and actually take some of the questionable bone out and bone grafting. But overall, the patients with most of the different types of cartilage restoration do quite well with the diagnosis of osteochondritis dissecans. Obviously, the first line of treatment is trying to repair it, but she was past that when she was referred to me.
And how does this particular patient that we're looking at compare to a sports person who's taken a bad knock on the knee and damaged the cartilage that way?
In many ways, it can look exactly the same. The difference is that typically those patients, when they get to a doctor, the bone portion has typically healed. Now, initially, if you have a direct impact, if you have an MRI, it's going to show the problems in the bone as well as the cartilage, because that'll show up as we call it a bone bruise or a bone marrow lesion. But once again, if you have a healthy knee and you just have a pothole in it, that is the best type of lesion to treat. The ones where you might say the whole road is washed out, those are much more difficult to treat. So this is the favored type of lesion to treat.
And would you say then that the recovery time would be affected by, for example, meniscal lesions that accompany that articular cartilage lesion?
Well, that's
we need you to define what you mean by meniscal, because the audience won't necessarily know.
The cushion of your knee, the thing that most people refer to as their cartilage in their knee, is really actually referred to technically as a meniscus.
Okay, we can have a little look here on the model.
Yeah.
Okay, so this is what you're talking about. So now I've flexed the knee, so I'm hyperflexing it. We're back again. This is with the condyle, and this is the tibia below. And on top of the tibia, in between the femur and the tibia, you have two little C-shaped pads. And those are the meniscal cartilage. That's sort of the confusion. The cartilage on the end of the bone is articular cartilage, and this is meniscal cartilage. So most of the people, when they say I went to the doctor and I had my cartilage trimmed, they mean the meniscus cartilage. That's much more common as far as an injury type, especially a sporting injury. They injure the meniscal cartilage at a higher rate than the articular cartilage. So that's what she was talking about.
Okay, Jenna, can we get back to your question? I'm sorry to have interrupted your flow.
Oh, no, that's quite all right. I was just curious if he found, I mean, when he was describing the ideal candidate as someone who just has a pothole in their articular cartilage, do you find that recovery time and surgical outcomes are unfavorably affected when you have an accompanying meniscal injury to deal with as well as that?
Well, it's a long answer, so I will make it a long answer because it can explain some of the complexities. So whenever we look at a patient, you know, what their mind is. In other words, people have to have a positive attitude. They have to be fully rehabilitated or prehabilitated. And then you look from the hip all the way down to the foot. And so that they have malalignment, that needs to be addressed. However you're going to do it, either with bracing or actually realignment surgery. If they have torn their ACL, that needs to be addressed. If they have torn their menisci, then you need to address it by looking at how much is remaining. We've done some biomechanical studies in the lab that showed probably if you have 5 millimeters or more at the periphery, you can treat it and leave it alone, and that's not going to interfere with your articular cartilage. If you've left it so that you only have just a small little rim, maybe 2 or 3 millimeters, you need to do something about that, and that's a meniscus transplant. When you start combining all of these things, and in some patients they have 1, 2, 3, or 4 different of these subset of procedures, yes, the results do go down, and yes, the recovery is much more difficult.
Okay, thanks. You said a few words there that maybe some people won't know. When you talk of problems that may accompany an injury like this, you talked about malalignment, and what you mean there is that when the two long bones, one on top of the other, are not in the normal alignment. Is that right? Or are you talking from the foot right up to the hip or the back?
So in this case, I was speaking specifically at the knee, and I was specifically talking about just what you said, the femur and the tibia. And if you want to think about, if you take a person and ask them to put their feet together, most people will have their feet touch, their knees touch. People who have, quote, knock knees, if they touch their knees, their feet don't touch. And if they have bowed legs, then their feet touch and their knees don't touch. Those are the people we need to evaluate for malalignment.
And the other thing, thank you, the other thing that you mentioned briefly was you said ACL very quickly. And perhaps you could just show us on the model what you meant by ACL? Thank you.
Well, fortunately, I don't know, maybe it's unfortunately, I think everybody in the audience and in the world knows what an ACL if they follow sports at all, because there are just so many sporting injuries. As you can see, I don't know how well this is showing up. Maybe I can go right up to the camera. There we go. You can see there's a little crossing sort of yellowish tissues in there. That is and the one that starts in the front or anterior, so it's anterior, as you can see there's 2 of them and they cross. That's why it's called cruciate, and it's a ligament. So that's where the term anterior cruciate ligament comes from.
Thank you. I have a nice little comment here that I would like to show you, where Carolyn Caperne says, you know a good knee surgeon by how close they are to a knee model. So, thank you, Carolyn. Right. I think we could go on to the next slide. Are you happy with that?
Yes.
Okay. Can you progress the slides, Debbie? Thank you.
So what we've done in this case, originally described by Lars Peterson from Sweden, he first published his results in 1994. He was using periosteum, which is the thin, it's a fibrous sort of tissue overlying our long bones. And he was using that as a patch to cover the defect. In Europe, they started using a porcine patch. It's collagen 1,3, so it's just a collagen material, no cells in it. And the advantage of that, some of my fellow cartilage surgeons, we got together and we compared our last 100 patients using the periosteal patch to our next 100 patients using this patch, which is the porcine collagen 1-3 patch. And we found a marked diminishment in reoperations because of periosteal hypertrophy. I know I'm throwing out a lot of terms, and you can pick them off one at a time. But basically, the patch would overgrow. So you would get good cell growth, but the patch would overgrow. The patient would have to have another surgery. They could still have a good result, but no one likes to have more surgeries than absolutely necessary. So in this case, I'm now trimming this patch so that it will match the defect. We're not going to show another slide, but that slide would show that I'm taking some of the cells and injecting them directly onto the patch. The patch has a very smooth side that's going to articulate with the rest of the joint, or that's going to be exposed to the rest of the joint. The side that's going towards bone is rough, and that allows the cells to adhere. And a German surgeon showed that the cells rapidly adhere. They adhere very thoroughly within 10 minutes. So from the time we apply the cells, we can then rapidly transfer it. So if we'll show that, well, why don't you ask me some of the questions? I throw out these terms without knowing that I do it. I apologize.
I'm going to. You're talking about taking this little piece of this patch of collagen,
yes,
and you're putting cells on it. Now, where are these cells coming from?
So prior to this, the patient had an arthroscopy. So as you can all tell, this is an open surgery at this point. So at arthroscopy, we do look around. So as Janet talked about earlier, what about the meniscus? Well, we look at both menisci, we look at the ACL, we look at the entire joint, assess how large the lesion is, and if it's a candidate for this type of treatment, then we will take a small piece of cartilage from the patient's own knee. It's in an area of very low loading, so we're not injuring the knee. And it's about the size of 2 Tic Tacs. And then we send it to a company, and the company has very advanced technicians that will take the piece of cartilage that you see physically, and they will digest it and bring out the cells. So from a piece of about 2 Tic Tacs, you may have maybe 200,000 chondrocytes. And then they will culture those, and they will go from about 200,000 cells to about 12 million cells. And then they will ship those cells in suspension to us at the time of this surgery.
And you take the collagen patch and you put cells on one side of it?
On the rough side, yes.
Okay, good. I think we can progress to the next. And the word chondrocyte means?
Chondrocyte is the term for the small cells that live within the articular cartilage.
Okay, good. Okay, thank you.
And this shows, so you can see that the patch looked a little rougher than it does now. It looks very smooth. That's because the rough side is down towards the bone and the smooth side is facing up towards us. You can see that I'm putting suture. This is very, very fine suture. It's 6-0. A lot of times we're using O and number 1. This is very, very fine. It's when I had to start wearing glasses, and I didn't stop. You can see the needle exiting the articular cartilage. When somebody told me you could sew into articular cartilage, I thought they were crazy, but it does hold quite well. And so the goal is to sew this so that you have a nice, smooth, sort of a manhole cover of this patch into the defect. And I think the next slide may be, these are the cells, and the amount of fluid, that's a little angiocath, and I'm going to take the cells out of this vial. The amount of fluid is only 0.4 milliliters, so a very, very small amount to have 12 million cells in. And then the next slide, we'll take those. So we've already applied cells on the rough surface, and now we're applying another vial behind the patch. So you can see my angiocath sort of tinting the patch. You can see that I've applied sutures, and they appear somewhat hazy. The reason why the sutures appear hazy is that I've taken fibrin glue. I think we skipped around on the slides. I've taken fibrin glue, which is a natural glue formed out of the same type of material in your body that forms clots. So it's fibrin glue, and have further sealed it so the cells won't leak out. I think that might be the last slide.
Yeah, that is the last slide. So I'm sure there are lots of questions. I can see Janet perhaps is burning to ask questions. Let's see.
Guilty as charged. I am absolutely burning to ask questions. So what is the length of time before you get fairly good infiltration of new chondrocytes into the area and some substantial tissue healing? What's the rehab course?
So the rehab is extremely important. With rehab, you can help the cells. As we all know, different tissues like to do what they do best. So hearts like to beat, and the muscles like to contract. And guess what? Chondrocytes, what do? They slide and glide and have repetitive loading. So they like to see early motion. So we actually put them in CPM. I put them in 6 hours after surgery. So they're starting gentle motion. And I go for as much motion as the patient can comfortably tolerate. So we want early motion. With that, we have a lot less adhesions. My reoperation rate is very, very low for adhesions. Then you ask a second question is, how do the cells multiply? Well, we don't do human experiments, but they do, animal experiments. And looking at those, we can make some inferences. And if you want to think of these cells, because it's actually a suspension, the cells start off very watery, then they adhere, and then they are still multiplying, they're migrating around, and they're starting to make the matrix. And if you want to think of this, so the stuff that we actually see with our eyes, that's the articular cartilage. But it only represents within that maybe 5% to 10% cells. So those cells actually make the stuff that's outside it. We call that the extracellular matrix, and it has proteoglycans and collagen. We can talk about those things. But over time, those become more mature and more robust. So it's sort of like Jell-O setting up. If you want to think about the first 3 months, it's that warm, kind of soupy Jell-O that's starting to set up. And at 6 months, it's pretty well set up, but it's not fully firm until maybe 9 to 12 months in most types of lesions. Some of them, it takes almost 2 years for them to become fully robust. That would be at the patella because that's the thickest articular cartilage that we have in our body. So during that time, the first emphasis is, and this is great talking to you as a therapist because I've not talked to you before, and I'll see how much you agree with this, but so I'm trying to load them but not overtax them. So I'm allowing people, especially for this lesion, they're minimal weight bearing, but I like to have normal gait minimal weight bearing. So when people talk about toe touch, I think that's very non-physiologic. So I like for them to go a normal gait, and they're putting 20, 30 pounds. They're putting the weight of their limb on it. And that's until, especially in these smaller lesions, a lot of these teenagers, they're off crutches when they come back at 4 weeks. Adults maybe 6 weeks. We keep low impact activities. I really like to emphasize core strengthening because it's great for the knee and yet is not impacting my implant at all. They start biking as soon as they can get on a bike. And so for the first 6 months, that's about where they're staying. From 6 to 9 months, they can gradually increase their activities as long as they have no pain and no effusions. Effusions means swelling. And then when do they get to go back to their desired activities? Typically, it's a year. And I know as someone who, well, I mean, I treat people who play sports, but when I have a discussion with cartilage restoration, my first discussion is, you have a knee that's not even giving you good function and comfort. They can't even walk around and they're still having pain. So our goal is to get you back for activities of daily living, comfort and function. If we can get you back to sports, that is icing on top. And it certainly does happen. I mean, everybody has examples of it, but that's not the number one goal. It's the number two goal.
I mean, could you make an estimate as to a percentage of, if you had your ideal candidate, would they be 50% likely to get back to some level of physical activity, not necessarily what they were doing prior to surgery, but, some level of a physically active lifestyle?
So we use different rating scales, patient-reported outcomes, and so they actually tell us how they're doing. And these are some that you would recognize, the KOOS scale, IKDC, and I know for our audience they're going, what's that mean? Well, basically we ask, these are internationally recognized scales, and they have questions such as, can you walk up and down stairs without pain? Can you squat? Can you get out of a chair? And then the COOS actually has sporting activities on sports and recreation. If you look at our overall results, and it's not just me, it's my colleagues, the good and excellent are about 80%. So we'd love to have 100%, but it's not. The reality is 80%. And then what that means is they can basically do all activities of daily living with acceptable comfort. And then those in the excellent category are those that are able to return to their sporting activities. This young individual has returned to all of her activities without pain or effusion.
So what would have been the outcome in a person like this if there had not been any surgical intervention at all?
So
what would the long-term outcome have likely been?
Well, there's two things. So this, what we saw was a defect. Well, on top of the defect was articular cartilage at one point. So what happens is it comes off like a trap door. And so this little flap is not very comfortable. So it's like having a rock in your shoe. So most people do come to surgery. So now I'm talking about the ones that are unstable and it's flaked off. There's all different grades. It's we could spend an hour just talking about osteochondritis dissecans. But the ones that are falling off, are going to fall off, those end up with arthroscopy. And they have looked at that, and what they find is those patients do quite well for 5 to 10 years. And at 15 to 20 years, a lot of them are starting to end up with arthritis. So and these are multiple studies in the literature. So our goal is to try to prevent that.
Dr. Farr, is there a point at which, like an older athlete, where you would not recommend this sort of surgery? I mean, does it depend on once you go in and take a look around, or can people 50 and older still hope that this sort of procedure might be a benefit to them?
Well, you never say never. The bulk of everyone's practice who does this are people under the age of 50. One of my friends, Tom Midas, published on patients, his older patient population, and I believe even his, when he was saying older, it's 40 years up to, I think maybe in the early 60s was his youngest patient. So, that's sort of the bad news. The good news is that we don't treat people based on their age. We treat them based on their knee. Unfortunately, when you get into your 50s and 60s, there's enough damage that this doesn't make any sense. Plus, you have to look at the risk-reward ratio. So, my personal history, I have a right total knee, and 6 weeks ago I just had a left partial knee. Could I find one of my friends in the world to do this cell therapy on me? I probably could. I could convince them. But it would be a year out of my life trying to recover, and my probability of having a good result may be as low as 60 to 70%, where I was back to work in a week after a partial, and it's going to serve me well for many years. So the risk-reward ratio for people when they can do well with metal and plastic, many times say, let's go towards the metal and plastic. But for the younger individual, if somebody's under 40, we try to do everything possible before metal and plastics even considered. I mean, I will try one procedure. If that doesn't work, I'll try a revision procedure. Between 40 and 50, I have a long discussion with the patient. Depends upon what their goals are. If they just like to walk, maybe some light hiking. They're a good skier and they just want to do greens and blues. I think metal and plastic. If they want to, be more aggressive, then we'll have to talk about, some other options. But yes, from a realistic standpoint, it's rare to do this in people over the age of 50. I know I have done a couple, and they've turned out well, but they had a knee that wasn't 50. They had taken good care of their knees and just had some potholes.
So would it be fair to say that if someone had this procedure done and they were younger, say in their 20s or 30s because of an injury, that it could possibly prevent then that continual degeneration, and they might eventually be avoiding a total knee replacement?
Well, that's our hope. I do clinical research, and so I don't like to say things unless I can prove it. So I can't say that. But having said that, Lars Peterson is a friend of mine, and I was talking with him at dinner one time, and he sees some of his patients that he treated over 20 years ago, and they're still doing well. I just saw, this is anecdotal, but a lot of anecdotes will eventually add up to a case series. A lady that is now 61, and I did her 12 years ago. I realigned her and did a very similar procedure, and her joint space is completely normal. And I can't believe, I mean, she was obviously having enough problems 12 years ago that we went on to that. So I think done right, and if they have a good outcome at 2 years, there's certainly a suggestion that we're going to have more sustained good results, and then hopefully avoid that sequela. At least we're putting it off. You know, to the flip side of that, I've had some patients now, I've been doing this for 16 years, I've had some patients come in who've had it after maybe 10 years, and they come in and say, you know, over the past year it's not working so well. We look at them and they do have degeneration, and I just show them the x-rays, explain it to them. I say, you know, you're really ready for medical and plastic. But I took them from maybe being 45 to 55, and they were very happy to get those years. And also, it makes much more sense to put metal and plastic in a 55-year-old than a 45. So even somebody else says that's a failure. Well, I think it's a bridge. We help them with their activity. Their lifestyle was better for 10 years, and now they have the next step.
I know this was a conversation primarily about knees, but I'm curious about the use of this procedure on other articular joints. In particular, you know, for example, femoroacetabular impingements, the top of the femur where it joins into the pelvis, often has articular defects. In runners, at least, can have an articular defect. Are they doing this procedure on joints other than knees, to your knowledge?
Yes. I know it's been used in the hip. It's quite frequent in the talus with ankle injuries. It's not quite used as often in the shoulder because the articular cartilage is very thin there as it is in the hip, and the hip is much more difficult to access. You can imagine trying to do that in the hip. So there's some other cartilage restoration techniques that they are using. Right now we have, so this is cell-based therapy. Everybody's heard of microfracture. I mean, that seems to be on everybody's tip of their tongue. 90% in the US, that's what's done. Osteochondral autograft, meaning it's sort of like a hair transplant, robbing Peter to pay Paul. So you're taking cartilage from one area and putting it into another, so that's done. And then allograft, so that's a cadaver donor. And then there's a young juvenile minced up cartilage. It's called de novo NT. I don't know if you've heard of that. It's been out since 2007. The first large series was, we just published it in AJSM this month. We have greater than 2-year follow-up on all the patients. And it looks like it's doing similar, probably 80% good or excellent in a large series, I would imagine. So each joint is going to have one particular type of cartilage restoration that's a little bit more amenable to it.
And do you find that the rehab is equally as long and challenging no matter what joint you do this in? I mean, a year's worth of rehab time can be daunting for a patient.
Yes, cells grow at the same amount, and they form the articular cartilage at about the same rate, so it's really site non-specific.
I was just hunting for a button here, but somebody's got there before me. So just let's have a little look what Heather Crafter says. I was told I need to replace both of my knees before I turn 65. I'm still under 40 for a couple of months. This conversation is hurting my knees. And I think she means laugh out loud because she's always laughing. So, Dr. Farr, I'd just like to try and put that into context. You were talking about a number of procedures for articular cartilage. In fact, there's an entire discipline now, isn't there, called regenerative orthopaedics, which involves techniques that are novel and interesting for the cruciate ligaments, for the menisci, for the articular cartilage. And to my mind, the entire entire emphasis is beginning to switch from saying to patients, go away and come back when you're old enough for a knee replacement, because we don't want to revise it and do it again and again, to come back when you're early, or come to us when you're early, and let us monitor you carefully and see what interventions need to be done in order to try and delay this metal on plastic, as you call it, as long as possible, and possibly completely. Is that right?
Well, I would agree with you. This is certainly an exciting time period. We're only being inhibited by how quickly we can get it to the market. There's a very lengthy authorization process under the FDA. Having said that, I couldn't agree more that, in fact, I put two different hats on. I'm a design surgeon for partial knee replacement systems, so I have been on that side. But when I put my cartilage restoration hat on, I want to see the patients early and I want to see them often, because I want to catch them before they go down that slippery slope. And if I'm going to intervene with cartilage restoration, if you have a pothole in your knee, just like if you have a pothole in the front of your street, it's never going to get smaller. It's only going to get bigger. So I want to restore somebody as soon as possible. So I'm early intervention. And when I say that, I'm not meeting somebody on Monday and operating on Tuesday. Usually it's a prolonged process. It's usually 6 months or so of getting to know the patient, fully evaluating their condition. But still, that's much earlier than saying, come back when you need metal and plastic. So in those patients that are early on, and certainly I think 40 is very young, I want to see if there is a biologic approach. It's not always possible, but many times it is. And I have to see, well, unfortunately, I have to tell people a lot of times that you don't qualify for biologics, and I don't think it's in your best interest. But since I do that, I would give them every chance, but I'm not going to put them in a category and do something to them that I don't feel good about, that it's not going to work in a high enough percentage. On the other hand, we do want to delay knee replacements, but there's some literature to show when you say delay, what do you mean by delay? I mean, I can remember when I first started to practice, people would say, you really shouldn't have a joint replacement until you're 65, or at least until you're over 60. And if you did a joint replacement in somebody in their 50s, your colleagues would kind of look at you crazy. Today, it's very common for people in their 50s to have a joint replacement. I had my first knee, I believe, I was 56. So, and then nobody thought anything different about that. But the key is you don't want to do it too early. You need to have radiographic parameters that say you are a candidate, that anybody would agree. So you have to have marked joint space narrowing. It's just not pain. It's joint space narrowing and arthritic proven changes. But the other thing is too,
what do you mean by joint space narrowing? Can you just...
Okay. So if some people have seen x-rays of their knee and they go, how are these bones hooked together? Why don't they fall apart? There's my femur bone, there's my tibia bone, and there's black space in between them. Well, that black space is the joint space. And what that's composed of is what we were talking about today, the articular cartilage and the meniscal cartilage. And the x-rays go right through them, so it's black. So you just see the bones. So the bones are white. The black area is just, it looks like a space. So that's what we're trying to maintain. And that's why I'm trying to put new cartilage in there, because if it erodes down the bone, there's no cartilage cushion, and so the femur bone is going to ride right on the tibia bone, and I would call that complete joint space loss. And anything less than complete is joint space narrowing. And so most people who will have an arthroplasty or a joint replacement, they're narrowed to maybe 1 or 2 millimeters. That would be most common. But let's say they have that, or they have, their pain is limiting their function, but their doctor says in the past, well, wait till you're fully bone on bone, or you're only 62, wait till you're 65. They've found that if you have radiographic changes to qualify for a joint replacement, then it's better for that patient to go ahead and have the joint replacement. And I'm not talking about age 30, but I mean the difference between age 57 and 62, what happens, and Janet maybe can comment on this, if you just endure the pain, most people are smart. If it hurts, they don't do it. So they take their life and they just collapse their life. They used to play tennis, now they play doubles tennis, now they can't play tennis, now they can't even go out for a walk, and they're debilitating, and so their function and comfort, even their social circles go down because they don't want to get out. It hurts too much. So go ahead and if you meet the radiographic criteria, if you're 62, 58, then do what your doctor says.
Do you find that if you refer patients to get an exercise regimen going prior to the surgical procedure, for example, you mentioned core stability and hip strength, I think is also a big part of that. Do you find that they're able to progress through the rehabilitation phase a little more easily? I know that some studies have been done on that with knee replacements, that patients who did prehab, for example, fared better in the rehab phase. Have you found that to be the case with this as well?
I would agree. And in fact, a lot of these patients, as I said many times, it takes 6 months to get the surgery. And a lot of times the pain has caused debilitation over time. And so they've been in a significant amount of exercise. And as you well know, that it's partly mental, so they're getting so that they can fully activate their muscles. They're familiar with their exercise program. Is trying to learn how to ride a bike after you've had surgery. It'd be a lot easier to learn before you have surgery. And so I couldn't agree more. I'm certainly a therapy advocate.
Thank you. Are there any other questions, Debbie? Do you have any questions?
I don't have any questions, just the observation that, having been, I'm a recreational athlete all my life, never, great at any of it, but I like the proactive spirit of, thinking about preventing further damage so that you can continue a healthy lifestyle, because I think, Janet and Dr. Farr, both of you mentioned people change their lifestyle. So it really is good to know that there are some options for people who are proactive about staying healthy even after an injury or some sort of a condition that is causing pain. So I think this is probably very good news for a lot of people who, and hopefully this will become available. You say it's still in the FDA approval process?
No, what I said was some of the new up-and-coming restorative procedures are in a series of FDA trials. I'm participating in a few right now.
So you're talking about procedures with stem cells, are you?
Well, I'm talking about a variety of things. I'm actually involved in a third generation. What I just showed you would be called first generation cell therapy. I'm involved, we could either term it second or third. Second is commonly referred to as when you're seeding it on a patch such as we're doing now, so we're sort of in between that. And then there's a variety when the companies are actually growing the chondrocytes on the patch, and so instead of having to sew it in, you can glue it in, and some techniques even allow these to be placed arthroscopically. So I'm involved in one of those studies. We recently published a stem cell study that we did several years ago. It was published in one of the orthopedic journals. The name of it's the Journal of Bone and Joint Surgery. It was published in January, and we found what we were trying to do is kind of an interesting study. We're trying to regrow a meniscus with stem cells, and we turned out we did regrow, but not significant enough. So that wasn't the real conclusion. But we found that the people who had mild chondrosis, if you want to call it almost pre-arthritis, over the course of the series, they had marked improvements in their comfort and function. So we kind of stumbled on to something that the stem cells in that case. And stem cells would be a nice topic, again, to talk about on another full series. But basically, people can think, everyone, when I talk to them about stem cells, they think of actually cells that are going in and growing you a new ear, a new bladder, a new knee, a new meniscus. Certainly they're working on that, but the more common type that we were using in that study is for the stem cell to reset the environment of the knee. These pre-arthritic knees, or the knees with chondrosis, the knee is irritated, it's very angry inside, and the stem cells are sort of like little chemical factories, and they help to reset the knee to a more homeostatic. In other words, the balance between inflammation and non-inflammation is at the correct normal level.
Thank you. That's a really nice explanation. So I think we don't have any more questions from our audience. Laurie I just know her as Laurie because her surname is difficult. Celiata, Laurie. She says to us here that, I'm officially an older patient. So she.
I'm an older doctor, so.
And Heather is saying that, just one moment, I have to work out how to get rid of these now. Heather is saying, yes, she agrees that you tend to collapse your life when you've got problems like this, and she's doing that with her own issues. Tennis, doubles, just exactly what you were saying. So, that's something that Heather has to consider now is whether she needs to consult somebody who can give her long-term advice and help her to understand what the issues are going to be for her future.
Well, unfortunately, Sheila, patients, they only know their symptoms, and the symptoms are not correlated at all with what's wrong in the knee. Janet can tell you that some of the most painful conditions, such as patellofemoral pain, it's strictly, in many cases, a therapy problem. So if this patient is walking around in horrible pain, they can go see Janet and they can be pain-free without surgery. That's the vast majority of patellofemoral pain. Whereas, some other people may be, having a very treatable lesion and they're just enduring the pain. So all they know, they have limited motion, they have fluid, and they have pain. And if you have those three things, then I think you deserve at least an explanation of what's the underlying process.
Mm.
Oh, I agree completely. I mean, get it evaluated by somebody who can do the diagnostic imaging like x-rays or MRI or CT scan and find out what's going on in there. But if it's not a cartilage defect that requires some sort of surgical procedure, you can make a lot of progress with some serious attention to strength building and flexibility building and, really getting your body back into a place where it can support itself. And even if it doesn't work and keep you out of surgery, it still will send you into surgery in a better place and in a better way to be able to come out of it healthy and strong.
Mm. That's a very nice way of putting it. Thank you. So it's coming on 7 minutes to the hour. I don't know if there's any more questions from anybody on the panel. Any more points you want to make? Okay, well, I'd just like you all to just think for a moment about whether or not you've got a takeaway for the patients. For example, I would say to anybody exactly what Janet has said. Don't accept the inevitable. Find out what's wrong with your knee. Educate yourself. Find out what the progression is of these knee problems. Find out what the options are, and find the right kind of person to help you. And don't neglect physiotherapy, because very often, as Dr. Farr says, you can be suffering severe pain, and it may not actually be arthritic pain. It may be pain due to another cause. So unless the patients are educated and get beyond this awful med speak jargon and into understanding simple things, they're not going to be able to to really understand what the progression would be normally. So Janet, do you have any more takeaways? You gave your takeaway very thoroughly. Do you have anything else to say?
Well, the only thing I have to add to that is that I'm really excited to learn about these procedures from Dr. Farr and to learn about some of the ones that are hopefully coming down the pipeline. I mean, nowadays with some of the miracles that we're seeing with 3D printing, you know, perhaps there are options in the future for being able to use a cell matrix in the 3D printing situation. You know, I think this is a very exciting time in orthopedic surgery, and as much as I try to cheat the orthopedic surgeons out of their surgeries by what I do, I'm really glad that those options are available and that there's more to come.
Great, thank you. Thank you very much. Debbie, any takeaway last message for
Well,
us?
just I really appreciate getting this explanation, and thank you, Sheila, for, you know, Dr. Farr has all this medical knowledge, but you are very aware of those of us who have no medical knowledge, but we need to be aware of what's going on with our bodies. So just getting this overview that was you know, put into layman's terms, explained the why and the how, and that, you know, that's very helpful, knowing that kind of information, so we don't have to be afraid to ask the questions when we go in to see our doctors. We have just enough of the right language and understanding to go in and maybe better explain to the doctor what we feel is happening to our knees, with this slightly deeper insight now about how this all works.
Thank you. Thank you so much. And Dr. Farr, we're leaving you with the last word.
Thank you. Well, Sheila, I certainly appreciate your time and expertise trying to help translate what I'm saying. I think it was interesting that, you know, Janet said that she's trying to keep patients away from me. I want her to. I don't want to. I really would like to have all my patients fully rehabilitated because so many of them can benefit from therapy. As far as the last points, I think patients can't tell what's wrong with them, and to just lay around and decrease your activity and function without knowing a diagnosis, it's a disservice to yourself. So I would urge patients to at least have it checked out by someone that's familiar with current cartilage restoration and arthroplasty techniques, and to select the best approach for that individual patient. Now
you use another big word, arthroplasty. What do you mean?
Joint replacement or partial knee replacement, sorry.
Okay. And I got a final message here, a last takeaway from Laurie. I'll just pin it on the screen, and then I think we'll stop at that point. Where she says, "Thank you so much, Jack Farr. Even though this didn't speak directly to my condition, I certainly learned a lot more about knee health. Debbie Davis and Janet Hamilton, thank you for asking such amazing questions. Sheila Strover, informative and elegant." Wow, that's nice. Okay, well, I think we'll leave it there. I'll just see if I can get my little buttons to work. There we are. Well, we did it. So it's just going the hour in a few minutes, and I think we might just say goodbye there and take comments in the comment stream later on. Dr. Farr, don't go away, because when we close the broadcast, we just can have a chat for a little while longer.
Very good.
Thank you. Bye-bye, everybody, and thank you very much.